and we'll get going in a minute. Remember that we are recording this, so if you do not want to appear on our recording, please turn your video off and your audio off. We ask that you use the chat function to ask questions or raise your hand if you would like to be unmuted to ask a question specifically. It's great to see so many of you. Hi, Sean. Hi, Karen. Hi, Beth. Great to see you. Welcome. Okay, everybody, it's 11 o'clock, so we'll get going. Hi, I'm Robin Shapiro. I'm the board chair of the Washington State Health Advocacy Association. We're delighted to be hosting another weekly community conversation. The community conversation is brought to you by WASHA, and we're a not-for-profit focused on promoting health advocacy in Washington State, empowering people to improve their health, and we seek to revolutionize how people see themselves by transforming care from patient to active participant and partner in your care. We are recording this event today, so please do not use your video or audio if you do not wish to be part of the recorded presentation. This presentation will be made available to the public. Please use the chat function to ask your questions, and you can also raise your hand or privately send me a chat if you'd like to unmute and speak. This is your community conversation. And I'm delighted to welcome today Dale Reisner, who is a doctor and medical director at Swedish Health Services for OBGYN quality and safety. She'll be giving us a medical update. And then we also are welcoming Fred Appelbaum, doctor, executive VP and department director or deputy director at the Fred Hutchinson Cancer Research Center. And he is also a practicing physician at Seattle Cancer Care Alliance. He is quite busy, as is Dale. And so we're very grateful to you and all of the frontline workers who are helping us navigate through COVID-19. I'd like to get right to it. So Dale, if you can give us an update from the medical system front, we would appreciate that.
Certainly. Welcome, everyone. I am thrilled to be able to participate in this community workshop. I wanted to let you know where we are in the state of Washington right now with COVID cases. We have definitely flattened the curve with our physical distancing, and you have heard me say in the past that we like to call it physical instead of social because we'd like you to stay social in whatever is a safe way to do that. That'll keep us sane while we're staying away physically from each other. So we are looking hopefully by the 21st of May to have 0 COVID deaths. Those have been decreasing as we go along. Right now, we are in the upper 700 range for total deaths in the state of Washington, and we think that will peak at about 870 by August. So we have some people that are currently sick that may not survive. We will have some new cases come along for sure. But this really slowing down is allowing the governor to start moving ahead. I hate to say opening because not everything is opening. And just so you know where we're entering, we've been in phase 1, which was really strict. And we're going to be moving into phase 2, which will allow for a little broader social contact. The idea would be that you would not be around more than about 5 folks that are not part of your immediate household, still keeping some physical distancing to stay safe, and that our number of our businesses and our parks and our sports and things like that will start becoming available to us. The other update I wanted to give is that although we have improved testing, there are pockets that have really ample testing, but the whole state does not. And until this whole state does, we will not be able to totally move freely because we won't be able to figure out who contacts are of new positive cases. And that's really critical for us to stay safe and not to have a second resurgence of significant, very sick people. The other thing that everybody wants to know about is vaccination. And I'm just gonna highlight, as I've done in the past, that the Pacific Northwest has been a central location for working on vaccines. Vaccines typically take years, and obviously there's lots of pressure. There are people around the world working on this as well, and there's a challenge because of overlap with coronaviruses in general, and being able to specify COVID-19 in any vaccination that's going to work for it. So I think Fred may talk about this a little bit when he launches his discussion. I think I'll stop with that for now and turn things over back to Robin.
Sorry about that, I was on mute. So Dale, one specific question. You said that we are on track for no new deaths starting the third week in May. That's something that we had talked about last week. Oh, let's unmute you. Oh, hang on.
I had muted myself, sorry. Yeah, a little noise in the background, so I'll keep muted most of it. Yes, we are on track. We will, as you move through this, you'll see small spikes in things as it moves on down the curve. And so we may have little bits and pieces of that, but most of the facilities that really mobilized, created COVID units, turned down their ORs are starting to reconfigure back to what we started with. We are opening up elective surgeries as of May 18th. That does not mean that every single person is going to come in. I know there is fear for folks to come to the hospital. And then, as I've said on past presentations, the hospitals are probably one of the safest places to come because everybody is very, very careful there, and we use PPE extensively. You're probably more likely to pick up COVID, from your local grocery store or drugstore than at the hospital. So if you need to be in the hospital, don't worry about it. We will be, for elective procedures, most places will be able to do some screening beforehand. So if you were to be an asymptomatic person who has COVID, has picked it up somewhere in the community, you would know that. And your elective case would be deferred till your viral testing is negative. So there's lots of safety measures that are being put into place as we slowly open those things back up again.
Great. That's really, really helpful. I just wanted to also remind people that if you do have a question that comes up during one of our presenters, you can just type it into the chat function. And we will obviously have a significant portion of time for Q&A. And with that, I'd like to welcome Dr. Fred Appelbaum, and just a giant in the cancer field. And we're so pleased to have you here to talk about how cancer treatment, diagnosis, what the situation is now and what it will likely be in the short term and kind of longer term, how things have changed with COVID-19. Fred?
Thanks, Robin. Thanks for having me and have a chance to talk with friends and community. Lots of things have taken a break when COVID-19 hit, so we're not, baseball isn't going on, and the NBA isn't going on, and parties aren't going on. Cancer doesn't care. It turns out it is still happening at the same rate, and frankly, for patients who are diagnosed with cancer, that takes precedent over everything else. certainly that creates much more of a threat than does COVID-19. So we are fully operational. We are seeing patients. We are diagnosing cancer. We're treating cancer. And anyone that has a diagnosis of cancer should not hesitate to continue to get their therapy. Now, we are doing things to try and mitigate the risk. And so, and I can only speak for the Seattle Cancer Care Alliance, the Fred Hutch, and the university. Different organizations might do things slightly differently. But do is before any patient comes into the clinic, we first call them at home and screen them to see if they have any symptoms. If they have any symptoms, we have them come through in a drive-by testing facility where they simply drive into the parking lot, are tested, go home. Within 24 hours, we have the result of that COVID testing, and if it's negative, then they come in as they normally would. We also screen everyone at the front door. And so when you come in the front door of the SCCA, you will be asked, do you have any of the COVID symptoms? And if, again, you do, you don't come in, we then test people and have them come back only when they are negative. Once you have been screened, screening is asking, testing is sticking something up your nose. So they're two different things. But once you're screened, you get a little sticker that says you have been screened. And you wear that anytime you're in the SCCA. We have mandatory masking of everyone within the facility at all times. You are permitted to, if you have cancer, you are permitted to bring someone with you it's very common that people do not want to go to an oncology clinic meeting alone. They need support, but we do ask that you limit that to one person if at all possible, and that person also needs to be screened to make sure they do not have any symptoms at all. A few of the other things we're doing is some of the visits we are now doing by telemedicine. This has really changed dramatically. I never thought I'd be doing consults about bone marrow transplantation by telemedicine, but I just got off the phone, had 2 appointments this morning before this call, seeing patients in that way. It actually works fairly well. In fact, some patients I think actually prefer that than having to drive to a clinic and come in. They can ask as many questions as they want, and we have a nice chat through telemedicine. We do have HIPAA compliant Zoom, which has to be used for these. And CMS has actually shown a lot of flexibility in that they now are allowing us very quickly to bill for telemedicine visits. It's a different level of billing. You don't have a facility fee, but there is a charge. So the doctors are putting in the time and getting the facility, the group is getting reimbursed appropriately. I suspect actually.
Do you find that the visits are actually the same amount in length, or how has the telemedicine kind of changed the nature of what you get done and the amount of time that you're using?
The visits, well, of course, telemedicine can't substitute every time. For certain conversations, it has to be more in depth, and for other conversations, you want to have a better assessment of the patient's physical capabilities, and you also have to do a physical exam. So it's never quite one-to-one. I think telemedicine visits tend to be a little shorter, actually, not longer, and it's not a substitute for every visit. But I think some of them really, I think you'll see a big change that people will be doing more telemedicine visits. And frankly, I think when you're looking right at a camera, someone, there's probably, instead of sitting over there and typing on your computer as you're trying to enter data, I think there may be, in fact, even as much of a personal contact. I think it works fairly well.
From the physician's perspective, is there a difference then in translating what you're doing into the computer? Like, is there transcription so doctors spend less time kind of typing everything in, or what's happening with that?
I think you spend a little less time typing stuff in with it, but I don't think that's changed. I don't want to get into the electronic medical record and all the bizarreness of that. Well, a lot of that's, also, frankly, a lot of the things that docs put into the computer record is for billing purposes. I mean, because you have to see so many systems and review so many systems to get a certain level of billing, as opposed to what's really important to put in there for the utility of caring for the patient. Because telemedicine doesn't have that same level of billing, you don't spend as much time doing all of that, frankly.
Gotcha.
That's
interesting.
Yeah, that's a little side bit.
Mm-hmm.
So we're still taking care of patients, for sure. We are changing how we do it a little bit to keep people safe. And I think we've done a really, really good job of that. My specialty is leukemia and particularly bone marrow transplantation. At the FCCA and the Hutch, we do about 500 transplants a year. These are some of the most immune suppressed people you can imagine. And I'm sort of proud to say we've not had a single COVID case among all of our transplant group, which I think is a testament to the caregivers, how good a job they do in protecting their patients and keeping themselves healthy as well. Mm-hmm. Now, there have been some other changes. Clinical research is incredibly important, and it's, what I spend most of my time doing. But there are some clinical trials which are not necessarily of definite benefit for the patient. Phase 1 trials, and of course the patients are informed about this. Phase 1 trials, for example, we're trying to find doses that are safe and potentially effective. And so in any of these clinical trials, we're constantly weighing the risk-benefit for the patient. And if we think that the increased number of visits that are required to conduct that research outweighs the risk of that outweighs any potential benefit, we have put some of those trials on hold. And so we're not closing the trials, but we have suspended accrual on some of them. We're starting to now relax that. And as the risk-benefit ratio we think is changing, we are starting to let more of those studies go forward. And of course, the biggest risk is for the patient risk-benefit that we're thinking about. We're also thinking about our staff. It's really, really important that we keep our staff healthy and capable of doing their work. We've been very concerned about having extra visits for data managers and for research coordinators and nurses as well. And so that's why we've tried to add enters into the risk-benefit ratio as well. And finally, of course, we're thinking about the strain on the healthcare system. Mm-hmm. How many additional, this is hard on everyone. How many additional visits it means to the clinic, how many extra hospital beds for people on clinical trials. And so we're always balancing all those issues.
Is your staff like the data people and those kind of folks, are any of them doing some of their work from home? Has it changed?
A lot of them are.
Yeah.
A lot of them are. So they're able to, we've allowed, in fact, the FDA has been very helpful as well. And they have relaxed some of the requirements for some of these clinical studies where it did the IND, in order to do the study correctly, the IND said these people have to be followed up in person weekly, for example, with a blood draw every week. And we have very quickly talked to the FDA, and they have allowed us to relax some of those requirements so we can talk to the patients by video rather than in person. We've allowed them to get blood draws closer to home rather than have to come into the research clinic. And so I think that everyone has been working really hard. I think everyone's been very reasonable. I mean, it's a complex system. I mean, our healthcare system is extraordinarily complex. And so to change everything immediately is very hard. But I think people have really tried really hard to make it work. And I'd also give a shout out to some of our employees who have, instead of when their clinical trials have been put on hold, they have volunteered to come in and do the screening at the front door.
Wow.
Or to be in the garage doing the nasal swabbing for the patients that have symptoms. It's been really extraordinary.
Yeah, that's amazing. And I was wondering, because I know as this whole thing started to unfold, we have a local cancer navigator here who has a company called Hartmut Stucker, who is, I don't know if he's on the line. But anyway, I was talking to him at the very beginning of this. And so his concern in getting patients into clinical trials was one of, are they going to put the clinical trials on hold, because it's so obviously clinical trials, as everybody knows, they're so strict in what you look for and how you do them. So how has this whole thing affected clinical trials in general? Like, are many of them on hold, some of them on hold?
So we have at the SCCA and the Fred Hutch writ large about 300 clinical trials ongoing. Wow. It's a lot of clinical trials. Now, some of them accrue lots of patients. Some are for very, very restricted numbers. We initially put about half of those on hold. 150 of them continued as they were, because we felt those were the ones that were of the greatest potential benefit to the patient, and also probably were on the lower side of risk. Now, but 150 continued to accrue. Of the other 150 that were put on temporary hold, we have now allowed about a quarter of them to start accruing again, and this week we'll move that up to about half of them.
Oh, that's great. That's wonderful. I'm just getting a question. Are there any phlebotomy labs that do medical house calls so patients don't need to risk leaving their homes? I don't know if you...
don't know that. I'm sorry.
That's a really good question.
Yeah. We have been doing some of that for our own patients that are at the Pete Gross House, for example, but I don't know the answer to that question. That's a good question.
Dale, are you
well, they're not the labs that I'm aware of, but there is home health. But home health has been significantly limited during the COVID pandemic. So yes, you can, for instance, get a platelet count, or if you're anticoagulated, you can get some of those assessments at home. Right now, I think the majority of that has been held back. And I'm hoping that as we move into this next phase, that some of those types of visits can get reinitiated, because some folks aren't that mobile separate from COVID-19, and having those home health care visits are really important.
And I'm just getting some suggestions from advocates who are on the line, specific names of labs like FIDA, FIDA, and Dispatch Health. So if people are interested in that, we can follow up. So thank you, folks, for forwarding Sean D'Amelio and Lisa Satan forwarding the names, and Julie Forkesty is also going to forward a name. So Schreiber, SCHRYVER. So maybe that's something that we can make available to people who are interested in that. Just send us a email at info@washa.org. But so back to the world of cancer. So Fred, how is the diagnosis process changed by COVID?
It hasn't, I think, in general, in the sense that if people have, I can't speak for community general internists, for example, but certainly if someone is referred to us with some risk of a malignancy, we would work them up just like we would work anyone up, because the delay in diagnosis is certainly outweighs any risk of COVID. And so we are continuing to do the routine evaluation of patients as we always would. Now, again, we are doing things to try and mitigate risk by calling people up and making sure they don't have symptoms before they come in for those tests, but we are still doing the full battery of tests just like we always would. Cancer needs to be handled promptly. It has to be handled thoroughly, and so we're not changing how we do that. Now, I suspect, and we don't actually know this, although we are launching a study to try and understand this, some of the routine screening tests have probably been impacted. We don't know how much that is actually happening. But statewide, I would bet you that there are fewer mammograms being done, there are fewer colonoscopies being done, and that's going to have a downstream effect if those things are put off for too long. So I think, in fact, I was just talking with Scott Ramsey, and we're trying to actually talk to all of the participants throughout the state to find out exactly what that impact is, and to try and do things to try and mitigate that, because we have to be very careful about COVID. Believe me, social distancing or physical distancing, whichever we want to call it, careful hand washing, wearing masks, all those things need to be done, and we can't relax that. But at the same time, we can't stop there are certain other things that the risk becomes overwhelming, and probably we just have to do both. We have to take care of our patients appropriately while we're doing the right thing in terms of protecting ourselves against COVID.
Mm-hmm. So, and we did have a couple other questions about screening, and in particular, somebody, and this might be you, it might be for Dale. Some folks have had experiences with screening where taking the temperature through various different methods yielded different results. And so that came from Maggie Pheasant. So I don't know if you or Dale want to comment on how screening is being done and how reliable the screening and testing is at this point.
Dale, if you want to go ahead, I can tell you that when we have been doing our screening, and people come in with any aches, pains, we include, of course, loss of smell as one of the unusual ones. So bony aches and pains, muscle aches and pains, fever, loss of smell, diarrhea, any of these symptoms, and we then do screening. So screening again is the questions, and then we test. We have been about at a 5% positive rate. And so most of the time, even if people have some of these symptoms, they will not be positive, but 5% will be. And that 5% need to know it. They need to quarantine themselves, and we have to be careful about who they come in contact with.
Yeah.
Dale?
Yeah, so I can speak to the Swedish system. Screening is exactly as Fred has said. We do have non-touch thermometers at our front entrance now, and do that forehead scan. So how accurate that is, I don't know, but it's going to pick up somebody who's got a real fever. And then the other thing is, when we do screen, we ask about whether somebody either has had a documented fever or felt like they had a fever. And if they feel like they had a fever, that is enough to recommend testing. But if they're coming in any reasonable sort of elective kind of or semi-elective reason. And certainly if they're coming in as a visitor. So very limited visitors. In the OB arena, they've allowed us to let the husbands in and a doula in for support if the person has that. All of those people get screened. All of them are given a mask at the door. So again, really reinforcing what Fred has said about the safety of the Seattle Cancer Care Alliance, about the safety of the majority of the hospitals that have any kind of a formal screening, and I think most of them do now. And that is super important for people to understand. Yeah.
Dale, we had another question come in a little while ago about when clinics and hospitals may welcome back visitors. Do you have any idea about that?
Oh boy, I think it's going to be a while before that opens up. I'm hoping that it's not forever, but we're going to have to be well into phase 2 and make sure that we are not having a resurgence of cases before that happens. And then I did want to add something to the cancer screening. So I was on a call for Olive Providence system the other day, and the focus was on breast cancer and lung screening, lung screening for high risk patients. And that obviously is a very different, smaller numbers and a different process than what a mammogram is, which is a high touch. So they are definitely rolling those things back out for the highest risk patients first. They will space out appointments, and they have, for instance, the portable mammograms, which do a lot of screening in the communities, have been utilized in downtown Seattle for screening for COVID. And they're repurposing them back.
Really?
For in the Swedish system. They just volunteered their vans to go down and do that. So they're bringing those back, and we'll be figuring out a way to make those available again in the higher risk population. So anyone who's been on hold, the providers that normally would have sent them in have been notified to get them back in. And most of the breast cancer screening institutions around the state that I'm aware of have lists and send letters out anyway to their higher risk patients. And then we'll get to the routine screen folks in a sort of second wave.
So I have a question about breast cancer surgery, and this comes from Dr. Seema Khan, who's a health advocate here, and wondering, Fred, if you could comment on the reports in the media about things like surgery for breast cancer being delayed during the pandemic and how that might be changing.
We have not, I can't speak for every healthcare system, but we have not delayed what we felt to be important operations that were time dependent. Now, there have been some procedures that we have put on delay, bringing people into Seattle for certain transplants, for example, where they could get closer to home one more cycle of chemotherapy before coming for the transplant, for example. So there have been some temporary delays, particularly we wanted to get past that surge where we felt the hospitals were going to be so overwhelmed potentially, because nobody knew how overwhelming it was going to hit Seattle. We did not know if we were going to be like New York City or we were going to be or not have that huge peak. I think that Seattle has done a terrific job compared to other cities. In fact, there's a very nice article in the New Yorker last week that people might want to take a look at that compares what happened in Seattle to what happened in New York City. And the reason that we've done so well, I think there's several reasons. One reason we've done so well is because we aren't as densely packed as New York. I mean, let's face it, we're just not. And the people pay a lot of attention. But the other is that we have spectacular epidemiology here. Trevor Bedford is a rock star who's been on the cover of, been on the front page of New York Times. He's a person at the Hutch who's been running the flu study, where we already had samples from thousands of individuals trying to understand how flu was going to develop in the community. And we were able to go back, Trevor was able to go back very early on and find that it had been in the community for weeks before the first case was diagnosed. And we knew, Trevor was able to predict how many cases there would be if we didn't start social distancing early. I'd also like to give a shout out to the governor. I think Inslee has been scientifically cognizant of what's happening. He's listened. He has listened to his experts, and he's everything that's been done has been done on the basis of data and science. And so we're very blessed to live in this community where we have such great science. We have bright people who are listening. We have people like you who are getting the message out. And I think that saved a lot of lives, frankly.
Yeah, wow, so exciting. Oh, and we also had a question about whether the Hutch is working on a vaccine. Actually, that came in. So
Um,
don't know if you
yeah.
don't know if you can say or
So,
not.
I,
Maybe.
oh, no, well, no, we have some, I think, some interesting, exciting news, actually. It's not official yet, but, the Hutch for quite a few years has been the headquarters for the HIV Vaccine Trials Network, the VTN, actually, nationally. We have that doesn't mean that we develop every one of the vaccines. We do work on developing vaccines, but we run the network that listens to industry and to science and takes the very best candidate vaccines and tests them for their safety and for their efficacy against HIV. That has been the principal investigator for that is Larry Corey and Julie McElrath. We have stations in South Africa, in South America, because if you're going to test the efficacy of a vaccine, you have to go where the disease is. Well, we've just been in contact with Tony Fauci, and it looks like the Hutch is going to be helping to, again, be the coordinating center for the development of coronavirus
Wow.
vaccines.
Oh my gosh.
So a testament to the science that is going on at the Hutch.
So amazing. That's just so exciting and so hopeful.
And I just want to say one other thing, though.
Yeah.
I think that everything that Dale has said, I absolutely agree with. But I just want to put one cautionary note. Yes, I think that we were on the right track. Things are heading in the right direction. But several of our virologists just warned us that we could see a second wave. And if people are not careful, there could be a second wave coming this fall, either because people relax too much or the new cases are brought in as travel starts to tick up again. So we're not out of this. We're going to be living with this for some time.
And it must be so challenging, both for you and Dale and all the providers out there who are trying to work in the moment that we have in front of us for patients and also be thinking about what could be coming. I would imagine that's really challenging.
It's yes, it is. It's also this is horrible. Don't get me wrong. This is terrible. There have been so many lives lost and economic burdens on people. It's just a tragedy. But I also say that it's, from a scientific standpoint, it's fascinating. It's fascinating to figure out what's the right thing to do. How do you do it? How can you both take care of cancer patients and keep them safe and keep your providers safe? It is an interesting time.
Yeah, so challenging. And it does also bring to mind, how do ethicists play into what is happening kind of day by day? I know I had met an ethicist at Providence and we were having a conversation, and she said, we're working 90 hours a week trying to figure out, and this was kind of early on, but how do hospitals, health systems, the Hutch, the SCCA work with ethicists? What's their role?
Well, that's a broad question. There's lots of different levels. One is ethical issues that surround individual patients. And there we do have an ethics committee that will help us. They don't, ethicists don't give you answers.
Right.
That isn't their
Ask
role.
questions.
They try and frame the question for you, so that they can narrow down the question of what you're really trying to ask in many of these ethical dilemmas. And so they help us try to ask the right question or frame the question in the right way. And so we do have ethics committees that do that. We also have a larger ethics committee that oversees all the activities of the Hutch, not about individual patients, but more policy. But some of the ethical questions are going to be much beyond any one institution, particularly when we have limited resources. How do we distribute those resources? When we start to get a vaccine, who gets that?
Yeah.
One of the things about a vaccine, there's not going to be one vaccine. There are many, many, many people who are working on vaccines. And some of the things you don't think about, for example, with HIV, if you have a vaccine that works a little bit, should you use it?
Right.
Because no vaccine is perfect.
Yeah.
They're going to have different efficacy in preventing disease, and they're going to have slightly different toxicity profiles. And so when is a vaccine good enough to put out there? And if you're putting it out for a billion people and it has even a very, very small toxicity, that's a lot of people that can get sick. In addition, a vaccine that's only a little bit effective may prevent people from developing an immune response to the next vaccine that's given, which people don't think about that.
Yeah.
And so it can block, and it can change. One of the big things with HIV vaccines were, well, if you get vaccinated, did it change your behavior? Would you put yourself at increased risk because you thought you were somehow protected?
Yeah.
So these are big questions that there are big ethical groups that oversee the vaccine trials network. And so they have a very large infrastructure to help address some of those fascinating questions.
Yeah. Yep. And I would just add that fortunately in our area, the hospitals, although getting prepared for what if we don't have enough resources, we never got there. And so again, another plea to keep doing what we're doing as much as we can, even as we open things back up a little bit, so that we don't end up with a second wave that's worse than the first. And I think that our state is well positioned to not end up being in limited resources. We had excess resources actually by the time everything was done. We sent ventilators to New York from the Swedish system because we had more than we needed by the time we had looked at what was projected to be our need and found that we didn't need it. So I believe I mentioned this before on one of the calls, and so I don't want to be redundant about it, but I really think some of what Fred has said, and as we look to, this is not the only pandemic we'll probably ever see in our lifetimes now, the way the world is globalized and the frequency of people moving around is going to go back to a certain degree. And that if we can be more global in the way we approach public health, then we're going to protect ourselves in the long run. I think you will see that, the plastic plexiglass partitions that have gone up in the grocery stores and all those places, they're not coming down after we get a vaccine. And so hopefully our behaviors will be a little bit more protective and we won't take things quite as for granted and still be able to get some freedom.
Yeah. This one's for Fred from Jim Best at Serenity Cancer Patient Advocates. And he says, Fred, you mentioned a second wave in the fall. We were just talking about that. And I'm a little more concerned about a second wave now in the states that are opening up. Do you mention an autumn second wave because you've seen robust data on the virus dying in the coming warmer summer temps?
No, we don't. We don't know why there is differences in temperature. Probably some people have said, well, let me back up. Many different viruses like flu tend to be seasonal. Understand all the reasons for that. It probably is behavior. It probably is kids going back to school, but certainly flu tends to be episodic where you have a flu season that comes in the late fall. RSV is the same thing, tends to come in the fall and winter. Temperature is probably not the answer for COVID, at least we don't think so. One of the worst hit cities in the world is Manaus, which is right on the equator. They don't have seasons; they just have hot, and they're in the throes of a terrible epidemic of it. So we don't know why there are differences from country to country. The reason I was simply saying that the fall is that just if you look at when just talking about we're going to be starting to open up during May, June, and July, and if we start to open up too much, that would just be the natural progression of reintroduction of the virus into the community and start to spread again. I don't think it's necessarily about the temperature. One thing I will say that'll be interesting, this is really tangential, but we may not see much of a flu season this year.
Why is that?
Because of all the social distancing we're doing.
Oh,
Yeah.
oh.
Yeah.
And so there may be,
Plexiglass.
exactly, washing hands, wearing masks. What works for COVID works for flu. And so the one small little blessing may be that we don't see much of a flu season this year. I think that's highly likely that we won't. We'll see much less flu this year.
So another question, Fred, from Leanne Biafora is, what is your organization doing with patients and families undergoing consolidation treatment for leukemia who would typically reside at a Hope Lodge?
Oh, right.
In Florida, they're having trouble finding reasonable accommodations for patients and families, so driving 2 to 3 hours a day to get treatment.
So we have both the Pete Gross House, we have the SCCA House, and we also have the Marriott right next door, for example. And the Marriott has been very nice about charging the same rent that the Pete Gross House has. So it's for people that have extended stays for cancer patients. They have rates that are, it's not free, but it's diminished. So leukemia is not something that you can fool around with. You need to get your therapy. You need to get it on time. You can't put it off. And so we continue to consolidate those patients just like we always have. We do have social workers who work to help them find housing either at the SCCA House or the Marriott or other organizations. I suspect the same is probably true at Swedish as well.
Mm-hmm. So Fred and Dale, here's a question from Dr. Steve Oberman, who you might know. He's a rheumatologist, among other things. This is a great question. What are your top 3 changes system changes in response to COVID that need to be maintained or need to occur in the future to be better able to meet the next pandemic? Good question.
The top 3 system changes.
Yeah, that's interesting.
I'm gonna have to give that a little thought because one of the reasons I think we've been able to handle this a little better is because with transplant patients and we have such a large number of very, very immune suppressed patients that we always are wearing protective equipment. We were also always screening people when they walk in the door of the SCCA. So we're used to this. This isn't that new to us.
Mm-hmm.
So I think from that standpoint, we're not changing things dramatically. I do think that the pre-screening has been effective to have people screen before they get there. And if they have symptoms, we can test them before they walk in the door. So we keep the disease from ever getting inside of the building. I think that's one. I think a second is, again, we hire people at the SCCA who do nothing but walk around the building and continually clean the elevator buttons, the door handles. And once they get from the 7th floor down to the 1st floor. They go back up to the 7th floor and do it again. And so we spend a lot of effort, and we always have, because we've had epidemics at the SCCA among transplant patients years and years ago. So we really want to make sure
So
that
is that something that's typically done in physical hospital systems, that type of cleaning?
I suspect that some of it is, but not, and Dale might want to comment this, but remember, we are doing over 500 allogeneic transplants a year. These are the most immune suppressed people you can imagine. So we're a little, we're sort of a little island that's a little different than much of the healthcare system is.
For sure. And, hospitals do clean those public spaces, but certainly not as meticulously as what Brett is talking about. And as meticulously as what is happening now. It takes a lot of people when you have a big building to do that. I think it's going to be I totally support those public spaces being kept cleaner. I think some laxity around where employees and providers eat and drink is an area that we could sustain that wouldn't cost money. But obviously there's a lot of strain on the healthcare system right now from financial losses. Both in elective procedures, but also in sick staff and having to replace them with travelers and other agency type people. So anything that we can do that doesn't cost extra money, that still keeps it safe, I think great benefit would be the verbal screening. I've suggested that we have an automatic virtual pre-op clinic. Where we can do that with telemedicine, and we can do verbal screening, and they can take care of the insurance information and make sure the pre-op recommendations are understood by the patient. You can get an interpreter on that instead of some of our sites have in-person clinics like that, and some of our known surgeries don't have that at all. So we've been pre-screening our planned cesarean sections, and now we're able to pre-test. So we're pre-testing anyone who's pregnant coming in for either an induction or a C-section. And there are places in the community, the University of Washington was able, because of their internal testing, they were able to do that sooner. And there are other places that can't do it at all. So again, that speaks to that it's not really uniform across the state that every place can do it this way. But the verbal screening everybody can do for sure, even if they don't have the testing. And calling and talking to people ahead of time are really valuable. So I think we should keep that up. I think telemedicine would help us. So we have, as Fred said clearly, open visits to telemedicine that we either have wanted to do for a long time or that we didn't think would work that well that have worked quite nicely. So it's not going to take away the in-person visit. And I think we talked a little bit last week with our psychiatry and social work guests that especially with an established connection, you can continue to see and counsel people with telemedicine and even telephone medicine in a better way than anyone would have thought. And telemedicine for psychiatry services in the state of Washington is something that is now being reimbursed appropriately and is much needed because of lack of resources. So that is both a physical deterrent to people having to travel far away or outside of their community, as well as opening up some non-physical visits to people who may not need to come in all the time. Our OB patients are being seen in person much less often, and in fact, it's fine. For most of them. High risk, a little different. Yeah.
So I'd like to actually go back and ask Fred another question about cancer patients being at higher risk, obviously, for COVID, and partners and caregivers. What do you have any advice specific actions or resources about how to protect one another and stay safe?
I don't have a simple answer. You know, COVID, the way you get COVID is that the virus attaches to these ACE2 receptors that are your nasal passage is very rich in. So the cells in your nasal passage have a lot of these ACE2 receptors. And the virus has to get on those receptors in enough to then get into the cell, start to reproduce in those cells, and then spread through your nose and into your lungs, and that's how you get the disease. So anything you can do to keep yourself from putting your finger up your nose, it's a good thing to do. Anything you can do to keep someone from coughing droplets that you then breathe into your nose is a good thing to do. And I mean, everyone has heard all of this multiple times, but you know, the cancer patients are immune suppressed, and because they're immune suppressed, that means that the virus has a better chance of reproducing in those cells in your nasal passage to higher numbers, which then allow the virus to get into your lung, which then allow the virus to spread through your body, which then can cause the pneumonias that are fatal, or the renal dysfunction, or the stroke, or all the other things that go downstream of that viral replication. The more immune suppressed you are, the longer it takes for your immune system to quell the reproducing virus, and that just puts you at increased risk. It also is an issue of the number of viral particles that get into your nose. And so if there are fewer that are getting in, it takes it longer to reproduce, which then gives your immune system more chance to fight it. So a big inoculum is worse than a small inoculum. So to say, well,
inoculum is particles.
The amount of virus, you know, whether it's a big blob of mucus that is just filled with virus, or it's a few little particles that happen to sneak in through the air. So it's not all or none. You know, people say, well, isn't it true that some air can get around a mask? Yes, it is. But does that mean a mask doesn't work? No, it doesn't mean that it doesn't work. It still works, it just doesn't work absolutely perfectly. But anything, so that's why even wearing a cloth mask, even if it isn't one of the N95s, is useful, because you will decrease the number of particles that you get into your nose. It decreases the number of times you'll touch your nose, just by virtue of wearing the mask. So wearing a mask, avoiding people that are coughing and sneezing. The 6 feet is, you know, not absolute. You know, the virus doesn't suddenly drop off the face of the earth, but it decreases dramatically the further away you are. So maintaining distance from anyone that's coughing or sneezing, wearing the mask, washing your hands, because the virus can live on some surfaces. But again, the risk of having someone deliver a bag of groceries to your door, and 2 hours later taking the bag and touching the cardboard and getting enough virus that actually causes a disease, I can't say it couldn't happen, but it's really, really small. I know Greg likes to say, you know, you can get herpes off a toilet seat, but that isn't how you get herpes. I mean, so it's the viral load. So yeah, you know, you can go to extremes, but the big thing is to avoid people that are infected, avoid people that are coughing and sneezing, wear a mask, wash your hands, maintain distance. Unfortunately, healthcare workers can't always do all those things. The nurses that are there beside the patients, and I mean, you know, we hear this all the time about how heroic they are, but they really are. They really are.
Yeah, absolutely. Wow. Well, this has been, the hour is evaporated. We're we're out of time, and I just want to thank again Fred Appelbaum. Thank you so much for your wisdom, for working through, you know, opening up insights that will help all of us hopefully navigate COVID in the future. Really appreciate it, Dale. Thank you. As I'm looking up at your picture, as usual, it's been so great to have you weekly giving us the updates about what's happening with the virus and what we should be able to do to mitigate our risk and what we might be seeing in the future. I'd just like to say thanks to everybody who is on the line. If you have found this event valuable, we ask that you do the following. Please fill out the survey that will be coming to you shortly. It'll be in your inbox, and provide us the gift of your feedback and let us know what you would like to hear from next. Join us this next Monday when we discuss navigating pregnancy during COVID-19, and Dale will be helping us with that. And 3, please support WASHA, and you can do that in a few ways. We're conducting our Give Big campaign tomorrow, and we're open for donations right now. If you're financially able to become a supporting member for $50 to help us run our organization, we would appreciate that. We know not everyone is able to give financially at this time, but we'd love for you to become a free community member of WASHA, and all of this is on our website. And with that, I would like to say thank you, and see folks again in a week. And thank you so much, Fred. Thanks for spending the time. Thanks, Dale.
Thank you very much. Thank you. Bye.
Bye.
Thanks, Robin, for hosting these. These are great.
Bye. Great to see you.